طيب, Bismillah. So we're going to talk about degenerative joint disease for the first lecture. So first we'll start with talking about articular cartilage. Articular cartilage is made up of hyaline cartilage. It's a viscoelastic material with variable load-bearing properties. It decreases joint friction, and it is avascular and aneural, meaning there's no blood vessels or nerve endings in the cartilage. The cartilage composition is made up of water, collagen, proteoglycans, and chondrocytes. Water makes up 60 to 80% of the wet weight. It's pumped in and out of the cartilage depending on load and contributes to lubrication and nutrition. Collagen makes up 10 to 20% of the wet weight, secreted by chondrocytes, mostly type 2 collagen, 90%, and confers tensile strength to the cartilage. Proteoglycans make up 10 to 15% of the wet weight, secreted by chondrocytes, composed of GAG, which is made up of aggrecan, chondroitin, and keratin sulfate. Negatively charged proteins hold water within the matrix and provides compressive strength. So the collagen confers tensile strength and the proteoglycans provide compressive strength. Chondrocytes make up 5% of the wet weight and they are the only cell type in cartilage. Could you please put your microphones on mute? So chondrocyte composition, the chondrocytes have little capacity for cell division in vivo, meaning that when there's direct damage to the articular surface, it is poorly repaired, or repaired only with fibrocartilage, which is of less quality than hyaline cartilage. It has inferior biomechanical properties compared to hyaline cartilage. If the collagen network is disrupted, the matrix becomes waterlogged and soft, followed by loss of proteoglycans, cellular damage, and splitting or fibrillation of the articular cartilage. Damaged chondrocytes begin to release matrix-degrading enzymes. Okay, so now moving on to the capsule and ligaments of the joint. The capsule is a fibrous structure with tough condensations on its surface that we call ligaments. Together with the overlying muscles, they help provide stability to the joint. Synovium and synovial fluid. The synovium is a thin membrane richly supplied with blood vessels, lymphatics, and nerves. It is the target tissue in joint infections and autoimmune disorders such as rheumatoid arthritis. So if you have septic arthritis or rheumatoid arthritis, it usually targets the synovium. It provides a non-adherent covering for the articular surfaces and produces synovial fluid. So synovial fluid nourishes the avascular articular cartilage because there are no blood vessels to provide nutrients to the cartilage. The synovial fluid provides the nutrients. It reduces friction during movement and has slight adhesive properties which assist in maintaining joint stability. The volume of the synovial fluid remains fairly constant, regardless of movement. When a joint is injured, fluid increases and you get what we call a joint effusion. So now we'll talk about the degenerative joint diseases. There are different types, but there's the primary or idiopathic osteoarthritis, which is a chronic disorder. It's progressive softening and disintegration of the articular cartilage. New growth of cartilage and bone at the joint margins form, and we call these osteophytes. The subchondral bone becomes sclerotic and forms cysts. So there's subchondral bone sclerosis and cyst formation. And there's usually a mild synovitis and capsular fibrosis that accompanies the arthritis. So If you look at an X-ray of primary osteoarthritis, there's asymmetrically distributed, often localized to only one part of the joint. If you look at this X-ray here, most of it is localized to the medial compartment of the knee, often associated with abnormal loading, unaccompanied by any systemic illness, not primarily an inflammatory disorder, although there are sometimes local signs of inflammation that accompany it. Not a purely degenerative dynamic phenomenon, it shows features of both destruction and repair. So now moving on to inflammatory arthritis, such as rheumatoid arthritis, systemic lupus erythematosus, Reiter's syndrome, Sjogren's syndrome, ankylosing spondylitis, and Behçet's syndrome. So it's usually a symmetric narrowing of the joint space. Periarticular soft tissue swelling happens. Periarticular osteopenia, so the bone adjacent to the joint becomes osteopenic. And there is usually juxta-articular bony erosions. So juxta-articular means next to the joint. Then we have secondary osteoarthritis. This is usually due to either trauma, such as an osteochondral injury or a malunion or a sport injury. It can be due to infection. It can be metabolic, such as gout and Paget's disease. It could be congenital or developmental, such as hip dysplasia, multiple epiphyseal dysplasia, and Perthes disease. Or it can be due to osteonecrosis. So osteonecrosis is what we used to call avascular necrosis. It's the same thing when blood supply to parts of the joint is disrupted. The bone dies and becomes osteonecrotic. It can be idiopathic or due to sickle cell disease or hemophilia or steroids. So etiology, how does it happen? The increased mechanical stress in some part of the articular surface. It causes a disparity between the mechanical stress to which articular cartilage is exposed and the ability of the cartilage to withstand that stress. The most common deformity is in the knee is varus knee deformity that causes medial compartment osteoarthritis. It is more a process than a disease and increases in frequency with age. Obesity plays a big role in developing osteoarthritis, but not necessarily. So not all patients who have arthritis are obese, but obesity increases the rate of arthritis. Hips and knees take 3 to 4 times the body weight with each step. So that's a huge load on these joints. And family history is also important in osteoarthritis. So there is an element of genetics with osteoarthritis. So prevalence, degenerative osteoarthritis is the commonest of all joint diseases. Much more common in some joints like the hip, knee, spine, and the fingers than others. So the elbow, wrist, and ankle are less frequent. More joints are affected in women than in men. Knee arthritis is especially common in our community, much more common in females, presents earlier than in the West. About 90% of those over 40 have asymptomatic degeneration of weight-bearing joints. The commonest joints are knee, hip, cervical, and lumbosacral spine. So we'll move on to the pathology now. Cardinal features are progressive cartilage destruction, subarticular cyst formation, sclerosis of the surrounding bone or subchondral sclerosis, osteophyte formation, and capsular fibrosis. So how does the subarticular cyst formation happen? It could arise from local areas of osteonecrosis or from the forceful pumping of synovial fluid through cracks in the subchondral bone plate. The subchondral sclerosis happens when the bone becomes exposed. It may be polished or burnished to ivory-like smoothness. Okay, we call that hibernation. So when there's no more cartilage protecting the bone and the bone becomes exposed, it becomes hardened and polished or burnished. Osteophyte formation happens because of proliferation and remodeling of the adjacent cartilage at the edges. And it undergoes inchondral ossification. Marked vascularity and venous congestion of the subchondral bone happens, and the capsule and synovium are often thickened, but cellular activity is slight. Progressive bone erosion or bone collapse happens. Fragmented osteophytes form loose bodies, and loss of height and ligamentous laxity causes malalignment. Okay, so all these are features of advanced osteoarthritis: bone collapse, loose bodies, and malalignment. Intermittent, so the clinical features of osteoarthritis is it has an intermittent course. There are ups and downs with periods of remission, sometimes lasting for months. One or two of the weight-bearing joints are usually affected, the hip or knee. The symptoms are pain, stiffness, and loss of function. So the pain is localized or rarely referred to a distant site. So, for example, pain in the knee can be felt from hip osteoarthritis. It is insidious in onset and aggravated by exertion and relieved by rest. In advanced stages, they start having resting pain and night pain as well. So why do the people with osteoarthritis have pain? Possible causes are that first, the bone pressure due to vascular congestion and intraosseous hypertension, and this is the most important cause. Mild synovial inflammation, capsular fibrosis with pain on stretching the shrunken tissue, and muscular fatigue. Stiffness initially after periods of inactivity, so when they first wake up in the morning or after periods of prolonged sitting. Later, it becomes constant and progressive and causes loss of function. Swelling and diffusion is usually intermittent, so they have periods with swelling and then periods where it resolves. If you have continuous swelling, that is usually due to large osteophytes rather than fluid diffusion. Deformity and malalignment, and also tenderness at the joint. So signs of osteoarthritis, again, limited movement, stiffness. They have crepitus, meaning that when you move the joint, there's a sound of crackling, and we call that crepitus, and that's usually because of bone-on-bone motion. And they can get instability as well with ligament laxity. So loss of cartilage and bone, and asymmetrical capsular contracture and or muscle weakness. So moving on to imaging now, X-rays will show asymmetrical loss of cartilage with narrowing of the joint space. So obviously, what we see on the X-ray and what we call a joint space isn't an actual space. It's where the articular cartilage is. But cartilage does not show up on X-rays. It shows up as a lucency, so we call it joint space on X-ray. They can have subchondral bone sclerosis. So if you look adjacent to the joint, you see some sclerosis, and cysts close to the articular surface. So you can see the cysts. on the right-hand side in the X-ray of the hip. Osteophytes form at the margins of the joint, and late features are malalignment, joint subluxation, bone loss, and loose bodies. You can have signs of other disorders such as symmetric narrowing in inflammatory arthritis, such as rheumatoid arthritis. So if you have symmetric narrowing in the medial and lateral compartments, that usually gives you an idea that it might be inflammatory arthritis rather than osteoarthritis. So what complications can form? You can get a capsular herniation. So knee arthritis with marked effusion and herniation of the posterior capsule, what we call a Baker's cyst. So if you have a large effusion in the knee, the fluid will try to escape through the weakest point and in the knee that is posteriorly. So they get this capsular herniation in the posterior part of the knee. How do we manage osteoarthritis? It depends on the joints involved, the stage of the disease, severity of the symptoms, age of the patient, and functional needs. So early treatment, we want to maintain movement and muscle strength, so range of motion and muscle strengthening. We protect the joint from overload and relieve pain, and we modify daily activities. So we ask the patients not to sit in positions of deep flexion for long times, try to avoid stairs, and try to decrease weight. So physiotherapy is very helpful in maintaining movement and muscle strength. Physiotherapy can help in pain relief when they do massage and application of warmth, prevents contractures. They do the muscle strengthening and range of motion. Load reduction on the joint. The most important one is weight reduction. As we said, the joints, the hip and knee joints, they get 4 to 6 times body weight with each step. We can use shock absorbing shoes. A walking stick also helps relieve stress on the joint, and sometimes we can use an unloading brace to shift the forces from the affected compartment to the less affected compartment. Modifying activity, so avoid activities like climbing stairs, and medications for pain control. Systemic medications such as paracetamol or non-steroidal anti-inflammatory drugs, or local medications such as injections. Injections are not highly recommended, but sometimes they can be helpful if systemic medications have stopped working. Now, surgical treatment. There are different treatment modalities we can use or that have been used for this kind of, for osteoarthritis. So joint debridement is one of them, which is done arthroscopically. Corrective osteotomies to correct deformities. Arthroplasty, which is joint replacement. And arthrodesis, which is fusion of the joint. So joint debridement is removal of, what we do with the joint debridement is we remove loose bodies and remove meniscal or labral tears in the joint. Corrective osteotomies, if the joint is it has a deformity, and we said the most common deformity in the knee is varus, then we cut the bone and realign it to redistribute the forces in the knee. And we realign the axis and redistribution of weight. This is indicated usually in young active patients who have mild osteoarthritis. If they have severe or moderate, then this probably won't work. The pain relief that happens after a corrective osteotomy can be from vascular decompression of the subchondral bone, and, as we said, redistribution of loading forces towards less damaged parts of the joint. Arthroplasty, or joint replacement, nowadays is the procedure of choice for advanced osteoarthritis. We do a total joint replacement. Knee, hip, shoulder, ankle, and elbow joints can be replaced. The indications are painful, deformed, stiff joint, usually in older patients. Okay, thank you. Any questions about degenerative